Section of this is the Easy IO. Some of you've already practiced with the skills of it back there, and IO should be kind of a refresher to you anyways, but you were doing pediatric IOs, we're doing the adult Easy IOs now. There's a very close similarity to how that small Milwaukee drill looks versus the ones that we carry on the truck, so just saying. Got a video from the manufacturer here to show you the insertion of the IO into the proximal tibia.
The best way is to try to find the patella and go 2 finger breadths, which is approximately 3 centimeters below the inferior aspect of the patella and 2 centimeters medial. So typically in most adults, the blue 25 millimeter needle will be the right needle of choice, but you have to account for soft tissue depth. So you might have to step up to the yellow or 45 millimeter needle. So choose the right needle for the right patient. After prepping the skin, which I've already done in this case, you want to apply the needle to the driver. It's a magnet that holds the needle in place. You want to stabilize the hub while you remove the cap. You want to insert the needle through the skin until you hit bone, and you want to make sure you see the 5 millimeter black mark to ensure that you have enough needle to get through the cortex. Gently advance the needle until you're essentially flush with the skin. You want to make sure you feel that drop or loss of resistance, and then advance another 1 or 2 centimeters. In most adults, you're going to apply this so that it's flush with the skin. And you want to make sure you're perpendicular to the plane of the tibia.
So I called the Regional Forensic Center and asked them to send me a picture of a tibia. They had a bunch of them, but anyways, he sent me a picture. This is Mary Marks. He's the anthropology doctor at the Forensic Center. He identifies bones and skeletons that are found out in trenches for a living. But anyways, this is the proximal end of a tibia, and on the right side here, this is the tibia plateau. This is the area you're shooting for. So if you measure two finger spaces down, it's at the second finger, not below it. So you locate the patient's patella, 2 finger spaces down at the second finger, not below it. That's where your device is going to be inserted. So it's approximately 3 centimeters below the patella and 2 centimeters to the inside edge, so to the medial side. There's what it looks like. The insertion angle, the way it sits, it should be sitting at a bit of an angle. When you push the needle in through the skin, you should be able to see at least one black line that lets you know that the needle is going to be long enough to get through the subcutaneous tissue and into the marrow space of the bone. Your blood is manufactured inside the marrow space of the bone, so therefore the flow rates and the vascularity of it is really good, so the medication administration works very well. Any medication that you give through an IV can be given IO, with the exception of blood products and medicines that have really short half-lives. So things like adenosine and succinylcholine cannot be given through an IO because they will be worn off or depleted before they reach their receptor sites. But anything else is pretty much fair game. The patient needs to be unresponsive for the EMT to do this because you can't administer pain medicine. If the paramedic chooses to do this on a patient that's awake, they're going to receive lidocaine as a local anesthetic, and they're probably also going to receive some sort of general anesthesia so they don't feel the pain from this as much, because it does hurt. The marrow space is very tight. It is very tightly interwoven with vascularity and nerves, so when you insert a foreign substance and an object inside of there, it's going to hurt really bad. So for optimal flow, you need to be using the pressure infuser. I think Jamie went downstairs and grabbed one. Pump up the pressure infuser until the pressure is inside the green area on the indicator, and that will help push the fluid into the osteal space. Here's another picture or representation here of what it looks like when you push the needle through. I need to be able to see one black line above the surface of the skin. That way we know that the needle is going to be long enough. Sometimes, if you use the red needle, which we no longer carry, the adipose tissue on a baby's chunky little legs, when they push it in there, it'll pop it back out, and now you've aspirated a bunch of fluid into a patient's leg. That can lead to compartment syndrome and severe infection. They could ultimately lose a limb from it. So we don't want any of that kind of stuff traced back to us. So we got rid of the red needles. We only use the yellow and blue. And make sure that you can see at least one black line before squeezing the trigger of the drill. This is what the drill looks like. You've seen it many times before. It has an indicator on the back. If this is green, that means your battery's good. If that light is flashing red, that means it might be time to replace it. These are sealed lithium batteries that cannot be replaced. You just have to replace the whole drill. The needle that connects on the end of it is magnetic. It pops into place. It can be pulled on and off pretty easily. This is the revised protocol that shows that we allow AEMTs to now insert them into the proximal tibia site for the adult, and you can also use the proximal tibia site for children. I heard many of you, and Rob was talking about, why were they initially letting us do these to kids but not adults? You could do more harm to a kid than an adult. That's kind of true. I kind of thought it was odd myself, but I will say that the bones of a child are not fully calcified, so they're not fully hardened. That means that they will heal back up. When you do this on an adult, there will always be a hyper-dense area afterwards that we forever change the anatomy of the bone. So on an adult, it's more of a permanent change, and on a child, unless you get into the growth plate at the end, you're probably going to be okay. There's an iPhone and Android application that's made by Teleflex that you can log into, and you can look at all these videos and all kinds of data and statistics information about flow rates and how well they work. We see a lot of times when we go to the hospital, a lot of places give us opposition about, oh, is that the only thing you got for access? Is that the only thing you got? They don't realize that the only thing that we have is just as good as an IV. They really want it, they're in a hurry to get them out. They don't want to leave them in. You've seen them when you come in, they immediately pull them out, and then they struggle to try to get an IV, and they're like, crap, maybe we shouldn't have pulled that out. Well, you're right, you shouldn't, because it was the only access that you had, and now you see why we put it in there. So that's the end of it. Any questions? For those of you that haven't went through the CPAP and the epinephrine stuff, I need you to hang out and do that. And I think, Jamie, did you get everybody through the King Airway and the drilling?
Yeah.
Okay, so those of you that haven't sit through and talked through the CPAP skills and the epi, hang out, everybody else will be free to go.
Just before, one thing